everyone. I, Samriddhi Pednekar from the marketing team of Hetero Healthcare Main Division, welcome all the esteemed doctors to this informative webinar. Today we are here to shed light on the topic influenza and its prevention and the potential role of oseltamivir in children. And to discuss this, I would like to invite our first speaker, Dr. Pramod Jog, one of the eminent pediatricians, President IAP 2016. Dr. Zog has 40 plus years of experience in the field of pediatrics. Also has done various IAP activities like Executive Board Director, Central IAP since 1992 for 9 terms. Has acted as National Co-Convener Art and Science of Pediatric Practice 2007, National Joint Coordinator Rational Antibiotics Practice 2014, Vice President Infectious Disease Chapter 2009 and 2013, and President IAP Pune 2006-2007. Also, Dr. Zog has been honored with various awards like Best Outgoing Student of BJ Medical College, Pune 1980, FIAP 1997. Also, twice he has won gold medal by BPNI. He is also a national trainer for Ask IAP, Science of Vaccinology, Allergic Rhinitis and Comorbidities. He has been a faculty member on over 2,000 national and international conferences, publications in national journals, and chapters in pediatric textbooks. Also, Dr. Zog has been a editor for Pediatric Review Journal since 1985. So, welcome, Dr. Zog, for this webinar.
Thank you.
Right, sir. I would also like to introduce our second speaker, Dr. Keur Mahajan. Dr. Keur Mahajan is MBBS DNB, Pediatrics Pune, Diploma in Pediatrics Infectious Disease, Oxford, UK. Dr. Keur Mahajan has done his MBBS from prestigious government medical college, Meerut, and has completed DNB in Pediatrics from New Delhi. Dr. Keur has been trained in Pediatric Advanced Life Support, Neonatal Advanced Life Support, Advanced Cardiac Life Support, and Basic Life Support. Currently, Dr. Keur Mahajan is a consultant pediatrician and departmental coordinator in Mai Mangeshkar Hospital, Varze, Pune. Consultant pediatrician at Shri Child Care Clinic, Shivne, Pune. Dr. Keur Mahajan has been handling all sorts of pediatric emergency as well as non-emergency cases successfully since last 13 years. And he has special interest in pediatric infectious diseases and respiratory conditions. So with this, I also welcome Dr. Keur Mahajan, sir. Very good afternoon.
Thank you.
I would request, I would hand over the session to Dr. Pramod Mahajan, Pramod Jog to take it ahead, sir.
Yeah, it's a good combination of Pramod and Keur Mahajan, making it Pramod Mahajan, but Pramod Mahajan is not here, so I will be scared anyway. Okay, with that lighter note, let us start with this discussion. I am very glad that this important topic is being discussed today, and Dr. Keur, my good friend and infectious disease consultant, is here to offer his comments. And I will start sharing my screen related to this particular topic, and I hope this is visible and I am audible. Keur, everything is fine at your end? Yeah, okay. Are you able to listen to me?
Yes, sir. Yes, sir.
Thank you. So now the topic is related to pediatrics, and we are discussing, many aspects about influenza, and this is pediatric perspective of flu. That is, the short form is PPF, and I am, acting maybe like a speaker or a moderator. So I am PPZ. So it is PPF being moderated by PPZ, and every flu virus has a nomenclature. Okay. So if you take Dr. Jog's nomenclature, it is like Z, that's found for the Jog, the place where the influenza virus is found, like Pune, then the month in which it is found, the year it is isolated, and so on and so forth. So basically, remember that every influenza virus is having some name. We will come to this particular nomenclature a little later, but let us start our discussion with a case. And this is a 3-year-old boy, and he has come to us with fever, cough, cold, and progressive breathlessness for the last 3 days. The parents are worried. A simple fever and cough and cold, parents are not worried. But here the child is getting progressively breathless and he is tachypnic. And the saturation of oxygen is 85% at room air. And the blood gases are shown in this particular slide. And this is the X-ray of the chest, wherein you can see that is a picture like ARDS. So everyone is scared. And the child gets admitted to PICU. The child is ventilated. The child receives oseltamivir and supportive treatment. And the throat swab shows H1N1 positivity. The child is ventilated for 3 days and then he becomes all right. Okay, this is a very short story that I have put for you. Now here, this child has received oseltamivir. And remember that when the initial presentation shows that the child is previously healthy and presenting with cough, cold, and fever, and there is progression over 3 days, whether this treating clinician have prevented this progression. That is the main thing, because everyone will like to halt the progression. And the next question is whether every patient of cough, cold, and fever be given oseltamivir upfront, particularly in the influenza season. And we are going to see as to what are the recommendations. So there are many points which produce what is called as confusion. It's the confusion about flu. And what are the various points where there is confusion? One, that whether this is bacterial or viral. Number two, if viral, which is the virus? Whether it is COVID, which we have seen for 2.5 years, whether it is rhinovirus, which is very common, whether it is adenovirus, whether it is influenza virus. Remember that the presentations of all the viruses which affect the upper respiratory tract are so very similar that it is, very difficult to differentiate one from other. I many times say that even Rajnikant would not be able to, differentiate the different viruses. Okay, if it is influenza, what is the type? Whether it is type A or type B, is it possible to differentiate? And these are the various points. And whether I should start oseltamivir upfront. We all know that whenever there is influenza, oseltamivir works best when it is given within 48 hours of the onset. But at this moment, we don't have the 100% foolproof diagnosis of influenza. So whether you should start oseltamivir upfront, and we are going to discuss some of these points, and whether I should give every patient an antiviral to play safe. Okay. So whether it is possible to attribute cold, cough, and fever to a particular virus. So we know that rhinovirus will come with runny nose and maybe some sneezing. We have seen adenovirus, which had a lot of contribution to increasing the practice of pediatricians last year and even this year, wherein the child presented with upper respiratory symptoms, but has other problems like some mesenteric adenitis, some pneumonia and some involvement of the eye and so on and so forth. We have witnessed COVID to a great extent, which has produced many problems, including pneumonias and loss of taste of sense of the smell, etc. And also we have witnessed influenza. Now remember that influenza basically is because of virus A or influenza virus B or influenza virus C, which is very much mild, and influenza-like illness, which is caused by a variety of other organisms, which are often called as flu. And that is why we should know how common this is. So as I was trying to tell you, when a child is brought to my clinic with headache, the mother says the child is weak. In fact, an older child is also lifted by the parents and brought. And I ask them, why are you lifting such an older child, who is 6-year-old, 7-year-old? So headache, myalgia, weakness. That is because flu is a systemic disease. It affects almost all the systems. And that is the reason why flu gets differentiated. And I told you that there is something like a flu-like illness. That means many other viruses can produce problem like flu. But the true influenza, A or B, that is the father of all the influenza-like illnesses. Okay. So it's around, 20 to 30% children, they have annually influenza. And the burden of severe influenza in India remains unknown, because not that every child undergoes some testing or the nasopharyngeal swab. Okay. And we should all know as to how this is transmitted. So you can see that it is transmitted by aerosol when you sneeze or cough, and the incubation period is very, very short. So if I cough or sneeze in my house, and if I have a partner by my side, within 18 to 72 hours of incubation period, the other chap also will get sick. Then the children will get sick, the grandparents will become sick. And we always discuss this, when more than one member in the family is involved, it is viral. And the most common is obviously viral, okay, influenza. So there is shedding of the virus, and you can see that the person to person transmission primarily occurs through contact with respiratory secretions, through sneezing, coughing, talking, touching, or the contaminated objects like fomites, like for example the handkerchief. Okay, so we will always see that these things are avoided. And in children, it's from the first day to day 14, and in adults from day 0 to day 7. And particularly those who are immunocompromised, patients who are malnourished, patients who are on steroids, patients have some other problem. Basically, the shedding is prolonged. And more severe the illness, more is the shedding, that all of us must remember. And the transmission by the body fluids and hand-to-hand contact is almost to the tune of 70%, while the airborne transmission is 29%. And there are some agents like bleach or 70% alcohol, which are proven to destroy the influenza virus. Now, a virus which earlier we used to call as swine flu, that is H1N1 2009 strain, infected person can shed the virus 24 hours before the symptoms start and up to 7 days later. Okay. And now the patient from the IT sector, information and technology sector, I funnily rather jovially call them as inquisitive and troublesome parents, IT parents. So they want us to know as to what is the classification of influenza viruses, because they are very, very academically updated people. So I tell them that the first isolation of influenza virus was from a pig in 1931, and then from the human beings in 1933, and there was a classification. And if you want to know everything about the influenza, I will call it as ABC of influenza. Why? Because there are 3 types of influenza viruses. And type A is the one which causes frequent epidemics due to minor antigenic variations. What are those antigenic variations? They are called as antigenic drift. That means, suppose Mayur becomes Kayur, it's antigenic drift. Okay, very little change in the name. And the periodic pandemics, they occur due to major antigenic variation or the shift. That means if Kayur suddenly becomes Pramod, then the total change in the name is there. This is a shift. This is the one which is associated with pandemics. Okay, and type B is the one which produces local epidemics in Pune, in Mumbai, in Andheri, and so many small places. And type C causes common cold-like illness. This influenza A virus is further classified into subtypes. And what are the subtypes dependent on? They are dependent on the antibody responses to the HA and NA. That is what I'm going to tell you in a minute. So these different types of HA and NA form the basis of the H and N distinctions. For example, it is H5N1. And remember that in human beings, H1, 2, 3 and N1 and 2 are commonly found. Okay, and the most prevalent human flu viruses are H1N1 and H3N2. All of the human versions of H1N1 and H3N2 can easily get transmitted from person to person because the H1 and the H3 proteins recognize the human cell receptors, making it easy for them to split into healthy cells. That is the reason why H1N1 and H3N2 are common. This is what I was going to tell you about what is HA and NA. Remember, HA is hemagglutinin, NA is neuraminidase. Okay, and you can see that these are orthomyxoviruses, and these two hemagglutinin and the neuraminidase, they are the ones which are present on the outer side of the virus. While influenza B is seen only in human beings, there are no subtypes, and it causes less severe disease, and it mutates at a rate of 2 to 3 times slower than type A, and it's common in children who are 5 to 17 years. And there is reduced rate of antigenic change, and combined with its limited host range, as I told you, it affects only human beings. So there are no major pandemics. Okay, and these HA and NA, which are there on the outer side of the virus, what do they do? So remember that hemagglutinin and neuraminidase, HA and NA, are the 2 large glycoproteins. They are on the outer side of the viral particles. And remember that HA mediates the binding of the virus to the target cell. So the virus enters into respiratory system, it gets bound to the respiratory epithelium. And neuraminidase is the one which is responsible for release of the virus from the infected cell. Okay, and that is the one which is responsible for replication. So when we use oseltamivir, which is neuraminidase inhibitor, it will stop the replication of the virus. Virus cannot go from one to other. Okay, and now these HA and NA, where do these new ones come from? See, there are 18 types of these HA and 11 types of NA. Okay, and if you do the permutation and combination, there are many types which come into existence. All of them, they circulate in the birds. Okay, and remember that the avian and the human beings, they are the ones which are responsible for these changes. Okay, so as I was trying to tell you in the first slide, I gave my own name, and this is the naming ceremony of the virus. So you tell about the type of the flu virus, the geographic location where it comes from, Minnesota, Australia, whatever it is, put in the name. What is the strain number? What is the year when it was isolated? Okay, so for example, type of flu virus is A. The geographic location is Victoria. The strain number is 361. Year of isolation is 2011, and that is H3N2. Okay, so this is the naming ceremony, how every flu virus is named. It's a very interesting and a naughty virus. Why I call it naughty? Because like the presidents of many academic bodies, the virus changes every year. RNA viruses, for your information, they are all very naughty. COVID virus, RNA virus, very naughty because they change every year. And that is why when you manufacture a vaccine against these RNA viruses, you have to repeat, you have to change, you have to manufacture these vaccines again, okay, next year, depending on the strain which is prevalent in that year, because it is possible that the viruses commonly circulating in the atmosphere might have changed. So the vaccine which worked wonders in 2023 may not work to that extent in 2024. It will work to some extent. However, it may not work to the fullest potential. And that is why WHO continues to collect information from different centers in the world and then gives the instructions to the manufacturing companies to produce a vaccine containing those particular strains. I already told you that there is something called as a drift and a shift. Drift means a minor change, shift means a major change. Okay. Now, this drift denotes a minor change in the hemagglutinin and the neuraminidase of the influenza virus, and this results from mutation in the RNA segments coding for either HA or NA. And this involves no change in the serotype. There is merely an alteration in the amino acid sequence of HA or NA, leading to change in antigenicity. Okay, and the major change is called as antigenic shift. Okay, as the population doesn't have immunity to the new subtype and as no existing vaccines can confer protection, shift has historically resulted in highly lethal pandemics. And remember, the conditions favorable for emergence of antigenic shift have long been thought to involve the human beings living in close proximity to the domestic poultry and the pigs. So people who are staying close to the pigs and the poultry, they are the ones which are involved. And as the pigs are susceptible to infection with both avian and mammalian viruses, including human strains, they can serve as mixing vessel for the scrambling of the genetic material. What does it mean? You can imagine that there is a bhel wala or a pani puri wala at the corner. That is the pig. He has a big vessel, bartan, and in that he has put sev and murmura and some many other things, onion and all to prepare the bhel. So some antigens from the bird, some antigens from the human beings in the body of the pig, they mix up, and the pig acts as a mixing vessel, and a totally new type of influenza virus comes into existence. And the vaccine which was received by the community earlier year is of no use because this is totally a new virus. Okay, this is what I'm trying to tell you, that birds and the human beings and the swine. Okay, so there is a transmission, and we can see pig to human. Now remember, when the pig transmits to the human beings because of the proximity, then human beings, they start from one to other, that is from human to human, and then the person gets high fever, cough, sneezing, breathing difficulty, loss of appetite, and all those symptoms which I told you. What happened in 2009 was a novel flu strain which evolved, which combined the genes from human, pig, and the bird flu. And as I told you, 4 major global pandemics have occurred till now. 1918, 1957, 1968, and 2009. And every time different viruses were responsible for the pandemics. As I told you, there have been no shifts with influenza B, and there is no animal reservoir, and there is no influenza B pandemic. Okay. Now in India, there is clear peaking of these cases during the rainy season and immediately following the rainy season. We know that in majority of the parts of our country, from June to August, particularly in the north, in the west, and in the east, we have clear peaking of influenza cases, while in southern parts like Chennai, between October to December, we have the peaking of the cases. Okay, so this is particularly true for India. Now, clinically, as I told you, how it presents is the abrupt onset. The child was fine till yesterday, and today the child has started getting symptoms. So, what are the symptoms? As I told you, the systemic symptoms are more than respiratory symptoms. Okay, they are more than any other respiratory virus. Okay, high fever, myalgia, malaise, headache. So all these are systemic symptoms. Okay, while other viruses, runny nose, light cough, and sore throat, these are the upper respiratory symptoms. They are okay. Rhinovirus and all, they will get produce problems like these. And then particularly there could be croup also. That means a croupy sound with stridor, or progression to the lower respiratory tract in the form of pneumonia. There could be GI symptoms. Remember, viral illnesses, I told you, more than one member in the family, more than one system in the same child. So the same child might have respiratory symptoms along with GI symptoms. Okay. And the febrile illness is roughly for 2 to 4 days, but the cough persists longer and it has a high transmissibility. So children will start the transmission from children to the parents. Remember, COVID usually used to transmit from adults to children, while influenza is the one which transmits from children to adults. And that's why children need to be immunized, and rather the illness needs to be controlled faster. And remember that the site of infection and the fever and chills, okay, are very, very important. The onset is sudden, and basically headache in flu is more severe as compared to common cold. So when symptoms are out of proportion to the duration of illness, you have to suspect influenza. Okay. And between 40 to 85% of infections with influenza, they result in clinical illness, depending on age and pre-existing immunity to the virus. Okay. So if a child is immune, he has received a vaccine in the month of, say, May, and there is some contact, say in the month of August, the child already has an immunity, so he may not get a severe problem. Okay. And that is why we have to have high index of suspicion. In neonates, infants, and prematures, there are particular clinical issues which we'll see in a minute. And there are certain differences between adult and the pediatric influenza infections. If you see, between 0 and 6 months, basically the burden of disease of this influenza is very high, and the fatalities are very high. Okay. Between 6 to 23 months and between 2 to 5 years, slowly and gradually, the burden of disease starts going down, and the fatalities also start coming little down. And there are some peculiarities of influenza in children. As I told you, it is highly contagious. And in children, the viral shedding basically is very, very high, and it continues for a longer time. Okay, so children continue to transmit for a long time, and influenza shows a close correspondence between viral shedding and the symptoms. See, if a child goes to a daycare or a preschool, then he is the one which is responsible for spreading it to the community. Okay. And then there are certain complications in influenza, the respiratory complications, otitis media. There is a typical time of onset of otitis media, 1 to 4 days after the onset of influenza symptoms. Then there is pneumonia, primary viral pneumonia, which is common in children with underlying risk under the age of 2 years. Suppose a child has some problem like a congenital heart disease, or he is premature with immunodeficiency state, then the risk is more. And usually this is Streptococcus pneumoniae or Staphylococcus aureus, which is a co-infection. There was a study where it was found that almost 25% of the influenza cases had associated bacterial pneumonias. And that is why, along with the influenza vaccine, it is necessary that the child also receives the pneumococcal vaccine, so that in general, the child gets protected. Okay. There are complications like exacerbation of conditions like asthma and acute laryngothrombosis, toxic shock syndrome, myocarditis, some neurological problems like simple febrile convulsions or influenza associated encephalopathy because of the cytokine dysregulation. We all are now aware because of COVID about this term cytokines, okay? And then acute necrotizing encephalitis, Guillain-Barré syndrome, aseptic meningitis. So all these are neurological problems. And many of our colleagues after COVID, they have published the case reports wherein they came across COVID and influenza rather on the neurological system. The same is true about influenza also. Myositis. Remember, this is more with influenza B. So the muscle pain will be the main complaint. And the child will say, the parents will say, he is always continuously telling me to press the calf muscles because they are paining. Okay. It is more common between 6 to 9 years in boys, bilaterally in the gastrocnemius and soleus, and there is severe bilateral calf muscle pain, inability to walk, and sometimes rhabdomyolysis. There are some hepatic complications, particularly in a child who receives aspirin, in a child who has influenza B. There is a syndrome called Rye syndrome, and this is fortunately now less common, but when we were residents, we used to see it to a greater extent. Now, when do you suspect H1N1 flu and what is influenza-like illness? Now, there are some CDC criteria for suspected H1N1 and the onset of acute febrile respiratory illness within 7 days of the close contact with a person who has a confirmed H1N1 influenza. That is the CDC criterion. Or onset of acute febrile respiratory illness within 7 days of travel to a community. Okay, and acute respiratory illness in a person who resides in a community where at least one H1N1 case has been confirmed. In short, you can remember that if there is a contact, then there could be various possibilities if there is a problem which begins within 7 days. Okay. And there is influenza-like illness wherein there is an acute respiratory infection with fever beyond 38 degrees, cough, and onset within the last 10 days. And there is a condition called SARI, severe acute respiratory infection, where there is a history of fever beyond 38 degrees with cough, with onset within last 10 days and requires hospitalization. Now, CDC, WHO, and IDSA, they recommend diagnosing influenza clinically and perform the testing only if the child or the person is hospitalized with influenza-like illness, patients who died of an influenza-like illness to clarify the etiology, or patients for whom the decision about infection control and the treatment of the contacts is a great concern. For example, child care and healthcare workers, nursing home residents, they need to be detected for influenza because they're the ones who are going to come in contact with other children, quite often. And that's why if a child in general is hospitalized or there is some death in the, community, which is, undiagnosed, one doesn't know whether it is a real influenza or there is some healthcare worker, then one has to be careful and one should try to diagnose by the nasopharyngeal swab. And there are some high risk groups which are likely to have severe presentation. And for the convenience of our listeners and viewers, I have divided into all those with C. So if there is a congenital or acquired immunodeficiency, cardiac, pulmonary, or other problems, then chronic aspirin therapy, compromise due to neurologic disease where there is impaired ability to handle the secretions, corticosteroids for asthma. Then I have written Charbi wale are the obese people, okay, and then those who are approaching 70, elderlies who are more than 65. So I am saying those who are saying chalo 70, okay. So remember all these C's, these are the high risk categories. Why I'm trying to tell you, because they are the ones who need to be monitored, and maybe in case if they start getting problems in a family where there is already influenza approved, they probably need to be put on oseltamivir, okay. And then there are grades of severity of influenza, which again have been categorized into A, B, and C. And in category A, the problems are mild with cough or sore throat, maybe with body ache or without body ache or headache. And then it should be monitored for 24 to 48 hours. And as far as possible, they should avoid mixing with the public. Here, this H1N1 testing is not required. There is category B where all these symptoms along with high-grade fever and severe sore throat. And remember, category C, Basically, there is influenza-like illness with breathlessness, chest pain, drowsiness. That means the lungs are now involved, and there is drop in saturation and worsening of the underlying chronic condition. So, from A to B to C, the severity increases. And when a child with influenza-like illness who comes to you, the parents have to be told that if the child is excessively sleepy, continues to have fever, inability to feed, convulsions, shortness of breath, difficulty in breathing, then you need to hospitalize and do the H1N1 testing and then treat it. And then we will do the nasopharyngeal swab or isolation of the virus in culture or fourfold rise in virus-specific antibodies, which would clinch the diagnosis. Now, when it comes to management, remember that the management should start as soon as possible after the influenza-like symptoms in the patients. They meet certain criteria. And remember that CDC recommends antiviral prophylaxis for persons who have had close contact with an infected person during the infectious period. Okay. So in addition to the supportive therapy, one should not wait for the laboratory confirmation of the disease if clinical suspicion is strong. That means if you clinically suspect that this chap is definitely rather indicating that he has H1N1 or flu-like illness or influenza, then most effective is to start oseltamivir before 48 hours of onset of the disease, particularly if the clinical suspicion is strong. Okay. And then what are the antivirals which are currently available for the treatment? So there are neuraminidase inhibitors and adamantins. For us, today we are going to discuss about neuraminidase inhibitors, which block the viral neuraminidase enzyme. I just told you HA and NA. And these are the ones which are critical in releasing the virions, that is the virus particles, from infected host cell. So these drugs are active against influenza A and B, and they are oseltamivir and zanamivir. Zanamivir is a powder that is inhaled and approved for early treatment of flu in people beyond 7 years. And newer neuraminidase inhibitors, which can be used intravenously, are like peramivir. Now, something about this oseltamivir, which is of importance today in our meeting. It was approved for medical use in the US in 1999. It was the first neuraminidase inhibitor available by mouth, and it's a potent and a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. And oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits the release of virions from the host cell and prevents further spread of infection. Okay. And as neuraminidase is responsible for cleaving sialic and neuraminic acid, it is one of the key factors responsible for influenza virions entrance and exit from the host cell. Inhibiting neuraminidase enzymes effectively halts the influenza virions' ability to spread to new human cells. That is why when the spread itself stops, the child will improve faster. He will not be required to be hospitalized. The chances that he dies are less. And that is how these are the important advantages. The child will not have otitis media. And remember, we must ask ourselves whether it really helps in influenza. Yes. So it will reduce the risk of otitis media. There will be reduction in the risk of lower respiratory complications because the influenza virus stops spreading. So otherwise it would have gone down to the lower respiratory tract, producing further problems. And then it will obviously reduce the duration of hospitalization, and it would lower the risk of severe complications, which would require ventilation. And even later on, suppose we ideally say that you start within 48 hours, but one should be clear that even when you start it beyond 48 hours, it has been found to be beneficial. And in some of the institutes where I have colleagues who are academically updated and who are involved in the research, they found that even if you started even after 6 or 7 days of onset of the illness, these antivirals like oseltamivir are of help. Okay. And there are certain doses which are, below 3 months, 3 to 5 months, 5 to 11 months. This is, particularly for children who are under the age of 1 year, when we give 12 milligrams twice daily, 20 milligrams twice daily, and 25 milligrams twice daily. And then beyond 1 year, the dose depends on the weight, and less than 15 kg, it is 30 milligrams twice daily. Between 15 and 23 kg, it is 45 milligrams twice daily. 23 to 40, it is 60 milligrams twice daily. And beyond 40 kg, it is 75 milligrams twice daily. And for adults, it is 75 milligrams twice daily. And the treatment is for 5 days. And in case if it has to be given for prophylaxis. Now, who are the patients where we need to give prophylaxis, preventive therapy? The chap is not unwell. The child is okay. The people in the family are okay. But do we give anyone? So pregnant women, persons who are at high risk of complications, I told you all those starting with C, healthcare providers and the emergency medical personnel who are not vaccinated. Okay, they are the ones where it is indicated. But if more than 48 hours have elapsed from the last close contact, if the close contact doesn't occur in infected phase or to healthy children and adults based on potential exposure, one may not give. But remember, for certain conditions, you have to give prophylaxis, and this prophylaxis is basically to be given beyond 3 months, and beyond 12 months, there are the dosages which are the same, but the thing is that it is to be given once daily, and that is for 10 days. So oseltamivir therapy 5 days, prophylaxis 10 days. Okay. Whether this oseltamivir is tolerated well, yes, it is generally well tolerated, but nausea and vomiting are the most frequently reported adverse events. Okay. And it's contraindicated in patients who have known serious hypersensitivity or severe allergic reactions, which have included anaphylaxis. Okay. And there are some limitations of use, particularly efficacy in patients who begin treatment after 48 hours. The efficacy may not be that great, but then as I told you, even if you start it late, it helps. Okay. And remember, it's not a substitute for early influenza vaccination, okay, or an annual influenza vaccination. And there is no evidence for the efficacy in any illness caused by agents other than type A or B. Okay. Remember, whether we can use this on suspicion. So if the tests are not done, but remember, tests are not recommended in routine cases. So if you strongly suspect, then you can use it before 48 hours. And you have to remember that you have to remember to use it only if the symptoms are highly suggestive of influenza, like headache, myalgia, weakness, and epidemiologically there is flu which is in the circulation. Because if you give it thoughtlessly, then as Sir Alexander Fleming said, the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with penicillin resistant organism. So we would start having resistance to this molecule. So remember, we should not use it indiscriminately, just like antibiotics. Use at the right time, but better late than never. And be aware of the limitations of this drug, including the adverse effects. As I told you, unless there are specific risk factors, you need not use it for chemoprophylaxis. So in category A, we have to use it for symptomatic therapy, where you have to avoid salicylates and assess after 48 hours. In category B, where they require home isolation and full course of oseltamivir and antibiotics if required. And category C, the severe children, severe disease children, oxygen, then airway, breathing and circulation, maintenance of hydration and nutrition, mechanical ventilation if required, and if necessary, a broad spectrum antibiotics with a full course of oseltamivir. Okay. So my dear friends, this virus is a fast and furious virus with onset which is abrupt, transmissibility which is high, progression which is rapid, ARDS which develops very fast. And my residents, they use the term vertical discharge whenever the child unfortunately is not around. So it leads to death very fast. And the only thing you have to do is give oseltamivir early. In addition to the preventive therapy and the vaccine, you have to follow some cough and sneezing etiquettes. Like, for example, you have to cough particularly in the elbow. Okay, this is called as Dracula cough. Okay, so this is particularly important, because then if you cough in the hands, then it will be a spread with the fomites. Okay, and you have to avoid the shake hand. You have to use a handkerchief, and there are different etiquettes particularly related to the hand, which I always say as hasta sutra. So keep other person at a hand's distance. Avoid shake hand. Namaste is better, and that is why I would say namaste. This is the last slide, so that you will keep yourself away from this disease, which is likely to progress rapidly. So with that, I will stop sharing my screen. And now, Dr. Keyur, whatever discussion, we are going to have is particularly related to your subspecialty of infectious diseases. Okay. And most important thing which I would like to know from you is that these days, I told you in the beginning, and I told the audience that it's very difficult to differentiate one virus from the other. Okay. And rapid advances have taken place in the diagnostic modalities in the last decade. So, when you are practicing as an infectious disease consultant, what are the various situations where you need to diagnose the particular virus? Because, when I was a resident, I never, rather, we never, bothered to diagnose the virus. In fact, the modalities were also not there. But now there are modalities like the examination of the nasopharyngeal swab, then the assay like biofire, and so on and so forth. So there are different viruses and the bacteria which are usually, it is possible to identify them. So I would like to know as to what is your way of approach to a child who comes to you with simple viral illness. Okay. As to the progression of the disease, the diagnostic modalities, and the therapy with oseltamivir is concerned.
Thank you, sir. Thank you, Hetero, for giving me the opportunity. And sir has very nicely given overall view of flu and oseltamivir. So I think most of the doubts has been answered in sir's lecture. But as sir said, most of the patients in pediatric OPD are of either respiratory or GI infections. So when there is a season, or then there is an epidemic, or when there is a, we say, ta season chalu zala. So when the respiratory patient starts picking up, so then we, as a pediatrician also and pediatric infection is concerned, so we are in dilemma because we see lots of, most of the patients have viral infections. But we are in dilemma whether this is having some superadded bacterial infection also, or is this viral, or is this bacterial, whether should I wait, or whether should I start with the antimicrobials, whether to start with fluvir. So as sir has rightly told that when there is any viral respiratory tract infection, viral upper respiratory tract infection rather, we can say that it will be associated with other symptoms of viral prodrome also, like myalgia, body ache, headache, rhinorrhea may be there, so throat may be there. So based on that clinical symptoms, we have to differentiate between viral and bacterial. If the child presents on day one of illness, we can ask them to follow up on next day and see how the viral program progresses. But also many times it may happen the child may not come for follow-up. So we have to keep in mind that what kind of patients are there, whether they're going to come for follow-up. But usually if their patients are coming on day one of illness, we may ask them for follow-up on after 24 hours and see how the viral program is progressing, not immediately start any treatment. If the child is stable and can be sent at home, as sir told. And if we are suspecting strongly flu, viral upper respiratory tract infection, then as the guidelines are there, see, the guidelines as sir told, category A, category B, category C, then most of the patients who are coming to our OPD in viral season, they, if they are having high grade fever, cough, cold, coryza, then they usually fit in category B. Okay, so then you may think of starting antiviral if there is ongoing epidemic. If you are suspecting that there is ongoing right now epidemic is going on viral flu, then without any diagnosis you can start antivirals, because they are best used within 48 hours, as I sir told. If the best benefit of antiviral you will get if they started within 48 hours. In IPD patients, they say that you may start the oseltamivir even if the child is having illness of 5 to 6 days. But on OPD basis, if you start in within 48 hours, it will best. So in routine practice, we don't investigate each and every patient on OPD basis for actual going for diagnosis of viral infection. Okay, so there are other viruses also other than influenza virus. RSV virus is there, adenovirus is there, parainfluenza virus is there, metapneumovirus is there. So other viral infections are also there. So if you ask, if you at all want to do investigations So then post-COVID, before COVID, there were no many labs who were doing PCR tests. But post-COVID, there are so many labs with whom there are different types of, say, the bunch PCRs are available. I will not say multiplex PCR or biofire because biofire is a costly test. Yeah, though it gives overall view. There are two types of respiratory biofires. If we discuss, there is a upper respiratory biofire and pneumonia biofire. Upper respiratory will we will take send a nasopharyngeal swab, and if we're having low respiratory tract infection, then we can see pneumonia biofire that is sent on the endotracheal secretions or bronchoalveolar lavage or mini bar. If we do on that fluid, we can send the pneumonia. So we will not discuss that part. But in upper respiratory biofire, there are different 20 to 22 types of viruses and bacteria altogether are considered. But frankly speaking, for OPD basis, this test is absolutely not needed. On OPD basis, actually, if you are clinically having strong suspicion in epidemic setting, you can start oseltamivir without investigating. And if at all you want to investigate, then investigation is only, see, when we used to send the upper respiratory PCR test, like in COVID setting. Like in COVID setting, the test was used to isolate the patient rather than the part of treatment. So in that setting, if we are having flu epidemic, if you are having flu and we want to isolate those patients, in those patients you can send the test on OPD basis if required. But on OPD basis, routine upper respiratory tract PCR is not required.
Correct. So now, Keyur, one difficulty which our listeners might have is that, many times recently I had a family from Kalyan in Mumbai. Initially, the small little, there were two grandchildren of the grandparents and parents. It's a family of six. And these two children, one after other, they were down with viral upper respiratory infection like picture, like maybe influenza-like illness.
Right.
Later on, the parents, they became sick. Then, the grandparents, they became sick. And one of the grandparents, the grandmother, had to be admitted because she became breathless. She was diabetic and obese. Okay. Now, at that time, her nasopharyngeal swab was done. And that RT-PCR came positive for H1N1. Okay. Of course, she was then, when she was hospitalized, she was put on oseltamivir. Now, retrospectively, the family, of course, this family was a medico family, doctor's family. So they just called me and asked me as to, in case if these children who were unwell for quite some time, like 3 days, 4 days, 5 days, 6 days, when they were only put on amoxicillin on the, on empirical basis, of course, maybe rational, maybe irrational, that's different. But then they just wanted to know as to why the treating physician did not start oseltamivir with these two kids when they were, when the fever was not going down and children were not eating, not keeping well for 5 days. Then so are our pediatrician justified in giving amoxicillin along with oseltamivir if a child is unwell for 4 days, 5 days? I understand that the best result will be there before 48 hours. That means if you start it before 48 hours. So if
Right.
such a child comes to you in the OPD with some, where the diagnosis was done at the end, that means when the last member in the family became sick, then the diagnosis, everybody thought of doing the nasopharyngeal swab. Okay, you get what I'm saying, no? So the point is that, many times there is a confusion that whether we should start antibiotics along with antivirals, and what are the conditions where you need to do this. I understand that it may not be very easy to answer in all these situations, but how would you look at these situations? Like,
So, as I said that upper respiratory tract infection, influenza infection, for say that they had a study and they have found that 2 to 5% of patients may have superadded infection in IPD patients. They have done in IPD patients, but to differentiate on OPD basis whether there is superadded bacterial infection, we can do a complete blood count and we can look at the WBC count. If it is on higher side, more than 15,000, we can think of superadded bacterial infection. If the child, even after starting oseltamivir, is not responding in 3 to 5 days, and the symptoms are worsening, we can think of superadded bacterial infection. If the child initially responded to oseltamivir, but again the fever did spiked again, that means the fever has settled, child was okay for 1 or 2 days, then the fever restarted. That position also we can think that there may be some superadded infection. Sometimes it happens that in our OPD the influenza like illness was there, we treated with oseltamivir and child goes home, and after 4 to 5 days again child spikes fever. Okay, so at that time we can think of that this might be a superadded infection which child had during his previous illness. So again, at a presentation only, when the child presents initially within 2 days, at that time, if it is very high grade fever and other signs of like what you say myalgia and other signs are not there, only symptoms are related to throat pain, and we can see actually there are some what do you say so tonsillar exudates and everything. And that time, if there are other corroborative signs like there is no diarrhea, there is no distress, no low respiratory tract involvement, only throat is involved, no conjunctival congestion, no myalgia is there, so no other mucosal involvement is there basically, because viral infections have other mucosal involvement also. So if it is only throat is involved, no other mucosal involvement is there, fever is high grade, you can see the exudates are there, so you can strongly suspect that this is bacterial infection rather than viral infection. At that time, you can start antibacterials.
Okay, so I think it's all ultimately an individual decision, but
Yeah.
a strong clinical suspicion based on a thorough clinical exam is
Yeah.
equally important, so that the pediatrician is guided accordingly. Because I see many pediatricians, again I would repeat, whether rational or irrational is another story. But what they do is, they many times, in the busy OPD, they directly start amoxicillin or amoxiclav along with oseltamivir. Okay.
Yeah.
So that's a very rampant practice. And,
Yeah. So
so what is your
they have done
take?
study actually. They have found that when there is a peak of influenza season, there is a rise in antibiotic prescription by 30%.
Oh,
Per 100 patients, 30 patients are written antibiotics without any need. So there is rise in 30%. So in this antimicrobial resistance era, this is very much difficult situation for us. So we have to be very cautious while writing antimicrobials. And that too, as we had a last month, last 2 3 months epidemic of scarlet fever, and we had discussed the indication of antibiotics in throat infection. And if at all you are starting antimicrobials, you have to get for proper duration, proper dose, so that also be kept in mind.
yeah, correct. But in general, all over those years of my practice and, my experience, I have always heard many of our colleagues, experts, user workers saying that the concept of secondary bacterial infection is something which is not very common in upper respiratory infections. Do you agree with this?
Yeah.
What is your opinion? That
Uh,
you said, I think that you gave some percentage of only 2 to 5%, isn't it?
yeah, it is very less. It is
So
very
that
less.
means suppose let us take an ideal situation where there is a proved viral infection, maybe any virus, rhinovirus, adeno, or RSV or influenza. So in your experience and your knowledge and your readings about various evidences, what is your opinion about the secondary bacterial infection in a child who has proved viral infection? I am sure it is not very high, no? What is
No,
your
no, no, sir. As I told you, no, sir. There I have come across the study they have studied IPD patients with viral infection, admitted with viral infections, and they have sent the blood cultures and all the parameters to search for the bacterial infection throughout their IPD stay, and they found that only 2% children got superadded bacterial infection. So it is
right?
very less. It is very less.
So I think our listeners must remember this fact because there is a rampant use of a combination therapy. We on one side combination means we first deplore combination of amoxi and clav. Okay, now this is combination of amoxiclav plus oseltamivir and God knows what else. But anyway, our listeners are wise enough to take the proper decision. Of course, there are situations where one is pushed to the wall and then one has to of course discuss. But I would suggest our listeners to at least discuss with their colleagues, seniors, or ID consultants like Keyur when they are, really facing some difficulty. So thank you, Keyur, for giving those highlights. So now, one last question to you from my side, only about the same thing, that what, as per your opinion, would be the indications for oseltamivir in the OPD practice and the indoor practice, so that, we'll have some good carry home at the end of this program. Like, where you usually in your practice start a child on oseltamivir?
So starting, so if before ordering any test, we keep in mind pre-test probability. What is the probability of this being any test being composed? Is like this: if any child comes with you in upper respiratory tract infection, you have to keep in mind what is the probability of this child being having influenza-like infection. Okay, so there are certain guidelines as you have disclosed that category A, category B, category C. So, but we have to keep in mind the epidemiology also. So whether you are treating this child in February, March, or if you are treating a child in June, July, August, September, so which is the peak influenza activity is going on. Okay, so if the child comes with high grade fever, cough cold, and rhinorrhea, some diarrhea, and there is peak epidemic of peak influenza activities going on in that particular time period, so my threshold for writing oseltamivir will be low. Okay, but if the same child comes in February, March, and there is high temperature, the influenza activity is very less. So in that at that scenario, I will think twice before starting oseltamivir, and I will look again after whether there is other viral infection going on or other things are going on. So it depends on the epidemiology. It depends on the what presentation is there, how high grade fever is there, what are associated symptoms are there, whether other mucosal members are involved or not. So whether we have to differentiate whether it's a viral or bacterial, and if we can accordingly start. It is difficult to actually give a verdict. This 1, 2, 3 you start, 1, 2, 3 you don't start. But it is our clinical acumen, how when the child is presenting, how child is presenting, what epidemiological things are going on. During that, accordingly, we have to start.
Yeah, that is true. And in the indoor practice?
Indoor practice, again, the same. If the high influenza activity is going on and the child is having a respiratory tract infection and he is having symptoms, see, whenever child is admitted for influenza, most of the times we admit when he has some low respiratory tract infection. When there is tachypnea is there, or saturation is low, or intake is poor, distress is there, X-ray is bad. Okay, in those cases, definitely you will start. Okay, so in those cases, if you are thinking of viral infections, then definitely you will not wait because the child is definitely in category C. So whatever is category A, B, C, as we have. So category C, we have to start irrespective of anything. So you can definitely start in those patients oseltamivir, and you can don't wait for test results. You can start empirically oseltamivir those patients.
Right, right. And do you agree with the statement which I made that even if they present late in the course of illness and they
Right.
are not doing well, continuous fever is there, or they have lower respiratory symptoms and all, so there is a point in starting with oseltamivir?
There are studies, sir. There are studies who have shown that benefit up to 5 to 6 days of illness you can start oseltamivir.
Correct, correct.
And that will benefit. That will cut down the duration of illness and improvement in the general well-being.
Right. Thank you. So, okay,
Thank you,
thank you for the inputs. And Dr. Prashant, if you have any questions.
Yes. Sir, it was a wonderful session, I must say first, eye opener to many of us, And as you rightly said, in a very witty way, I mean, a combination of antibiotics is one thing, and combination of an antiviral antibiotic, we are going to, we don't know what. And another witty remark was Pramod Mahajan, I must say. Sir, we all said that when you put the patient on oseltamivir, the duration of illness comes down. Is it that the intensity of illness also comes down?
Yeah, my answer is yes. That means the severity of the illness comes down.
Yes.
Because the viral, the transmission of the virus from one cell to other stops. The viral load will decrease, and I'm sure you will agree with me. The
average
severity
duration, So there are
Yes.
studies which have shown that average duration of 1 day, average 1 day duration of illness curtails.
Correct.
And again, the symptoms also.
Correct. because I mean, reducing intensity of symptom in a child is a big thing. No? I mean, for the parents, and the hidden benefit of putting the patient of oseltamivir, as we saw it during Sir's presentation, is that not only you take care of the child, you take care of the chain of events that is happening, even the transmission up to grandparents. I mean, that could have been avoided at some time if the child
Right.
would have been put.
Right,
Yes.
right. Because I will tell you, in the family these days, if you see husband, wife, 2 children, and maybe
Exactly,
grandparents. Now,
exactly.
it is possible that the mother is pregnant, the father is
Absolutely.
diabetic, the grandmother obese, and the
Correct.
grandmother asthmatic. So some risk factor with somebody is always there.
Absolutely. Yes, yes,
So,
yes, yes.
and the transmission from child to these high risk people, if it stops,
Huh.
same.
Yes.
Yeah. So same
I mean,
same logic we extend even to the vaccine also. So if a child is
absolutely.
vaccinated or in a sick child, if you give oseltamivir early and the child improves, then it's better, because then the transmission stops. Yeah.
Yes. If the child is say, vaccinated, would prophylaxis further help?
Yeah,
Ah.
prophylaxis is actually indicated in vaccinated children also. There is no differentiate between whether
No,
child is
no. But what I'm saying is that suppose the child has taken an influenza vaccine, would giving him a prophylactic treatment with oseltamivir further help the child in terms of duration of illness, in terms of intensity of illness?
Yes. That's what I'm saying. That chemoprophylaxis, there are indications of a certain, as sir have told, that indications of chemoprophylaxis. But even in vaccinated children, the chemoprophylaxis will help definitely.
Yes.
Yeah, correct.
Yeah.
It
I
is
will tell you.
indicated in vaccinated children also. So it is not that you are taking vaccines, so you don't need chemoprophylaxis. Even in vaccinated children, if you are exposed to flu, the patient who is having flu-like illness within 24 hours, you can start chemoprophylaxis.
Yes.
Another important thing that Sir said is that it is best, the flu is best diagnosed clinically. We need not wait for the laboratory investigation in all the patients and start the treatment empirically, possibly.
Yeah, whenever there is, as we said, high index of suspicion clinically,
Yes.
there is epidemiological setting, and some point in continuation with that vaccine question which we are discussing.
Yes.
It is important to note that earlier we were under the impression that the vaccine has this efficacy almost lasting for 1 year. But now I keep hearing experts saying that it's only for 9 months. Some people say only 6 months.
Okay.
So after 3 to 4 months, I start getting jittery whether this vaccine, So when we give it just before the rainy season, because rainy season is the main season, for example,
Absolutely. Yes.
the child has been protected in that season. So that is the logic of giving it before the monsoon. So at least during the rainy season, the child is protected with vaccine.
Yes. You get
Later on, the antibody titer may start going down. God knows how long it continues. But it is not as long as 1 year as we were thinking. So there are experts who are now thinking of suggesting 2 doses of influenza vaccine. Even so of course this is just I'm telling you as a part of discussion. Not that it is a recommendation, but then there are people who have started seriously thinking whether we need to give 2 doses in a year. One, in the month of April, May, or maybe other one in October, November, something like that. Okay. So that's why oseltamivir will definitely help even if the child has been immunized in the past. Yeah, sure.
So wonderful. So that's all from my side. It's a wonderful session, I must say. Eye opener for oseltamivir. I think there's a little hesitation in prescription of oseltamivir somewhere, I suppose, or maybe it's not real. People have not realized possibly the benefits of oseltamivir prophylactically.
Yes, I agree with you. So thank you, Dr. Prashant, for the questions.
Thank you so much. Thank you so much.
Yeah,
over to you, madam.
Yeah, Dr. Samruddhi.
Yes, sir. On behalf of Hetero Healthcare, I extend my gratitude to all of you for your participation. I really thank you very much, sir. Thank you.
Thank you, everybody.
Thank you,
Thank you, sir.
Bye.
Bye.